All right. All right, welcome, everyone. We understand that you are hearing us. Thanks for joining online. Of course, thanks for coming live. We're making a change of the two seminars that we have today because our speaker has had a car trouble, and she's all good and fine, but she's gonna run a little late now. It is with great pleasure that I actually get out of the way to introduce you our first speaker, all the way from Chile originally, but based here in Australia, the University of Sydney at the Menzies Center for Health Policy and Economics now. That's right. I understand. So Dr. Gabriela Uribe, her role is a research fellow at the Menzies Center. And she's currently managing the Center of Research Excellence for Integrated Care, Community Care for People with Complex Multimorbidities project. It's a mouthful, a very important project. And the connection with Gabriela has been through a long-standing collaboration we have with the Menzies and Professor Gillespie. So thank you, Gabriela, for joining us today. She will talk about COVID and public health restrictions and the way in which they impacted, in particular, disadvantaged or vulnerable groups. Please, Gabriela.
So, hello, everybody. Thanks for coming today, and thanks for the ones who are on Zoom today. Today, I'm going to talk about a study that we conducted with multiple partners, with people at the LHD, Sydney local LHD. We're going to also have collaboration with people based at the ministry and also University of Sydney and other universities. So this is a study that we have conducted together as a group and as part of our CHERE, our Center of Research Excellence in Integrated Health and Social Care. And what we did with this study was to measure the COVID-19 impacts and how those were managed by using public health restrictions and measures and different policies, and how those affected our more vulnerable priority populations. And this is a study that is being conducted in Sydney Local Health District with a population study approach. So a little bit of the background and a little bit of why we decided to run this study in particular. So we all know, obviously, the high impact of COVID-19 in our nations around the world. And what we did to prevent and to mitigate the COVID-19 risk and poor outcomes. So what we basically had to do is to adapt our behaviors. We didn't have a treatment or medication. So what we did, we went and imposed restrictions of movement. People couldn't go to work, isolation, quarantine, and many of these were obviously behavioral rather than anything else. And we also know that vulnerable communities, such as migrant people with low socioeconomic status, were disproportionately impacted by COVID-19 and outcomes and risk. Yeah. So as I said before, we had these priority populations and we identified them, and it could be minorities, it could be people with disadvantaged backgrounds, people usually that might not have the health literacy that we would expect to manage their own health status and issues. We also found by reading and other evidence outside of Australia that there were minorities were affecting, they had higher rates of COVID infections. We also know that some priority populations do suffer for comorbidities and multimorbidities, including social multimorbidities and also health. And we have a little bit of evidence in Australia saying that people that were born overseas, from specific countries, have increased mortality due to COVID-19. So what do we did as a country? So we come up with a few strategies and a few rules that were, I guess, developed and imposed by different levels. So in terms of the federal level, so our government come up with international travel restrictions, with a very tight quarantine program, with residential subsidies, payments to employers and employees, administration of free vaccines, and some additional clinical and telehealth services. I mean, everything was shifted from a face-to-face to more virtual services. Now, for this part, I would like to be very clear that this is what it's been reported in is on paper. So what we did as a country at a federal, a state, and then a local level might be slightly different of what it is reported or is in paper. So when we talk about people working on the ground, they might say to you, well, yeah, that was the original idea, but we had to change just to face and just to respond to the dynamic environment that COVID was presenting to us. So it might be a little bit inaccurate, not because they don't want to be transparent, but they just have to adapt and adopt new strategies arising from what the initial plan was. So then at state level, we all know about public health orders. They also implement testing facilities for the community free of charge, some contact tracing, and the mass vaccination clinics. Then we have an LHD level. They were in charge of control tracing as well. So they have like shared responsibilities between the state and the local government. They have vaccination programs, inpatient virtual services, and international travels. And they also come up with a concept and with a program that it was the special hotel accommodation where they're taking care of people with health conditions within a much more controlled environment. And it's an extension of the hospital services to them. By the way, as I said before, with the local districts, there was a little bit of, I guess, the plan. They had a plan, and then they have to change a little bit of what they were financing. The vaccines rollout got a bit difficult, so that's a little bit of inaccuracy in there. Especially because they have to fund it as well to some extent, get what they needed by that time, and because they want to accelerate the vaccine program, for example. So they have to come up with new strategies and ideas. So in terms of social policies, this is about job seeker was extended and increased. There was a job keeper program as well. There was disability care and family assistance payments. We saw that there's also grant to community services, so people were able, from a community service point of view, to acquire some funding to run some programs and help others. There was a lot of, so the social care really emphasized the well-being of both people with comorbidities and people that they were catering before them. There were some housing and homeless preventing programs arising from COVID-19 and try to contain and reduce the risk of getting COVID-19. There was emergency accommodation for isolation, and there's a very good couple of examples of how the local governments manage the COVID spread in more vulnerable populations, our regional populations specifically. And they were supporting aged care, mental health and disability, and carers, or at least this is in paper. So in terms of our local health district, so we had some anecdotal data saying that priority and vulnerable populations were facing with difficult challenges. So we know already there are disadvantaged, and there's existing disadvantages already known, but with COVID-19, things got a little bit more difficult. So as a LHD in Sydney Local, they did try to establish strategies to communicate with leaders in these communities to try to be, I guess, facilitating vaccination and testing. So in terms, what is the context of this study? Why are we doing this? So there's two, I guess, the two main focus was to just describe the socioeconomic and the risk of COVID-19 outcomes in the whole population study. So you run this in a broader, with a broader view. But also we want to identify trends of outcomes of COVID-19 in all the LHD catchment area during strict and relaxed restrictions. And I'm going to explain that two different time cohorts next. So as I said, it's a population-based study. We had the whole set of data for the whole LHD. So single local LHD, it's comprised by around 650 to 700 populated residents. So we had that data for us to run this study. And that data was obtained through the performance unit in that LHD. We did also have data on COVID cases, hospitalization and death, and we got that data from the Menzies database. We had the vaccination status of the whole population, and we linked that with the Menzies database, and we got that linked by local government areas. Just as a way of information, so in Sydney, there is around 8 different LHDs, local health districts, which is the way that we separate, or I guess have different governance of what happened in the service provision in that specific territory. And the one that we are looking at today is the one that is circled in orange, the Sydney one. So, okay, we also got demographic characteristics from the census, the ABS census from 2016. And this is important because then I'm going to talk about that. We used the 2016 as opposed to using the most recent, which is 2022, because at the time of the study, the 2022 census, they were still collecting the data. So we needed to use whatever we have at that point. And we linked the Menzies database of COVID outcomes to the ABS by small geographical area, and that's what it says there, SA1. So we had a few different outcomes, but the primary outcome was infection. So COVID-19 infection was our primary outcome. We also have secondary outcomes, which were testing, hospitalizations, and death. In terms of the two last ones, and this is more anecdotal and historical, is that the hospitalization and the death rates were not too big when we were running the study, the study design, because in general, we as a country did not have that much, but we did have obviously infection rates. And we linked that information and we used demographics to see what were the effect of these demographics on COVID-19 outcomes, including vaccination status. So in terms of the data itself, so we use a thing called relative socioeconomic disadvantage. This is from the ABS. This is telling us what that particular group, what is the level of disadvantage, and you can go from very, very little disadvantage to very big disadvantage. We also did a little bit of a spread in terms of the region of birth of the people living in the LHD. And we categorize them following the World Health Organization categories. So then you have different places and regions of country of birth. And we also use household size to see whether higher household size or reduced household size will have an impact on COVID-19 infection. So the vaccination status was defined as having 2 doses, not just 1, 2, not 3 or 4, 2, and recognized by the TGA 2 weeks and at least 2 weeks prior to infection. And we did also have, because later on in the results, you will see that we had 2 different variants. One was Delta, that was corresponding with the first time period cohort, and then the second was the Omicron. So here we got to the part of the actual study design and how we decided to actually draft this. So we had strict restrictions, and we measured infection in there. The strict restriction mean that we were having the whole full lockdown. This is in Sydney, obviously, so we were very restricted. We couldn't move. I think the only thing we could do was to go for a walk, essential shopping, work from home. And then we had the relaxed restrictions. And these will obviously pair with vaccination rate and how the increase of the vaccination let us relax all the rules we had. So that was from October to February. And the same length or number of days for both different ones. So in the relaxed restrictions, we were able to go and visit family as Sydney Local West was opening again. We run our logistic regression model. We put all the demographics in it, and then we ran two different models, two separate cogs to see the restricted period and the more easy period. And here we go with the results. So what you can see there is our data, our comparison data between the strict and the relaxed. You can see there quite easily that the strict restrictions did help on protecting us as a community against the COVID-19. So as soon as you open the country, the LHD, you can see that the number of infections obviously increased. Okay, so the first thing that we can see there is that actually the restrictions did work. Then what else I have there is that the strict restrictions were really good at protecting people, all the cohort people, 80 and over, compared to us obviously to that. Because what happened when you open the LHD, it didn't matter how old were you, it didn't matter any of your social status or demographics. So we all got infected. And we will see that in some geospatial graphs I have later. But basically, when you open the country, although we did find significant difference anyway, they were not so strong. So all the demographics, I don't know, it didn't matter anymore. So here we go, again, the same model, strict, relaxed. The first image this is people in the lowest SES, so the most disadvantaged of all, had 7 times the risk of infection of COVID-19. Okay, so you got there, you compare the same thing when the country opened, and the risk, although we still find significant differences, it wasn't that sharp. The next bit, it's about the gender. So the strict restrictions, the risk was higher for males. You can see that the odds ratio, the hazard ratio, and then again, the same thing happened when we opened the country. It didn't matter your gender, it didn't, all your demographics were, it didn't matter. So, and here we have the household size. For the strict measures cohort time period, people living in high household sizes, the risk of infection was higher. And then again, the difference were significant anyway in the relaxed, but it wasn't that powerful. Now, in terms of the country of birth or region of birth, because we categorize as regions, we saw that people being born in Middle East and North Africa region had more risk of infection of COVID-19. The South Asia region also have, and then I just put that as a mean of comparison really, because the same story goes for that. So as soon as we open the country, the LHD and the rules relaxed, still significant. And you can't forget that this is a population-based study, so the numbers are big. and answer B. And there is significant difference, but because we had a large number, it made a difference in terms of significance and non-significant. So this is the other outcomes. So we're not talking here about infection anymore. We're talking here about the money and how the index, the disadvantage index, affected the testing and the hospitalization and death. So people living in these more disadvantaged areas, like low SES, had lower dose of testing, hospitalization, higher odds of hospitalization and death due to COVID-19. Areas where the most common country of birth was not in Europe or Australia, and Europe, by Europe I mean or like Caucasian, had reduced odds of testing, but not difference in odds of hospitalization or death, except for East Asia. And here we have the comparison between Omicron and Delta. So the Omicron variant of COVID-19 was associated with lower odds of hospitalizations and deaths. That's better with vaccination rate, by the way. So here is the photo I was referring to before. It looks a bit complicated, but it is not. So you have the strict restrictions versus the relaxed restrictions. You have colors, you have red and you have green. The red will be the most disadvantaged people. The green would be the less disadvantaged people, so higher SES. The round, the bubble, the size of the bubble is the number of infection. So the bigger the bubble, the more infection. And here, this is the map of the Sydney Local Health District catchment area. So here you can see this. So in this photo number one, what you can see that there's people with very low SES getting a lot of infection. And not many people with high SES getting infection. And then what happened is that we open the LHD, restrictions are easing. You can see that doesn't matter how, your SES, the infection rates are kind of similar. So just to sum up, we sought to identify demographics and socioeconomic factors associated with COVID-19 outcomes in a very specific area, having a look at the strict restrictions versus relaxed restrictions. We saw that the strict restriction period and the measures within that time frame were effective in reducing COVID-19 infection rates, right? And we saw also that those protected the elderly and the higher SES groups. And our findings are kind of consistent with what everybody else is saying in other places. We also found, though, that people living in large households, people with low SES, and some migrant communities in Sydney local were impacted disproportionately. And I guess that we know that there is disadvantage. So that there were distinct and existing disadvantages. There were. But I think COVID and the context of implementing these measures as we were going, because it was kind of a very dynamic environment. And the effect of doing as we were facing all these issues, unfortunately, didn't have, I guess, it didn't help as much as it helped others in the general community. So obviously, we have limitations of this study and the study design. It was retrospective. It was more about what data we had available, routinely collecting data. So the data that we used wasn't, I guess, it wasn't thought to be a research project. I don't think that also was data that was collected in the view of analyzing this retrospectively. I mean, how did we deal with this? So obviously the design has some flaws. So we were comparing two different groups of people at two different times. And those group of peoples were perhaps having different community attitudes. There were different COVID variants at the two different time points, which might affect the infection, it might affect the death. There were, as I said before, vaccinations rate were changing. And we also have the seasonal effects of making, the seasonal effects saying, well, we were looking at more winter time when we were in Delta and more like summer, kind of spring, summer in Omicron. So that makes it a bit, I guess, very hard to interpret the results. Now, there's also the second flaw is that we use data from 2016. It wouldn't much be better to use data from 2022. And the reason is pretty simple is because in 2016, we had a more stable population within the LHD. As soon as COVID hit, people started to move. Some people lost their job, went to regional Australia. There were people coming from overseas and needed to leave for XYZ reasons. People couldn't come back. So I guess the ethnicity makeup, the socioeconomic makeup of the people living in that LHD changed completely. And even the numbers. So there was internal migration, external migration. So the numbers were a bit. So that's a point that we have to have in mind, that we use data when the population was completely different at what it was when we were facing COVID-19. And the other thing that also, I guess, made things more hard to interpret is the testing methods and testing preference. So we were having different testings coming along depending on what was available to us.
What happened?
Sorry.
突然有人开始说英语，就是他就申的是计算机的嘛，他就申的，对，他是那个 NCI 的计算机。
We hear you, Amy. If you can mute yourself. Amy, oh yeah, that was a very drastic mutation.
And we had the strengths, so we had present the limitation and now the strengths. So we had a big cohort. We looked at like big data, and we effectively having two different public health responses and measures, which allowed us for evaluation of public health responses in the context of socioeconomics and other factors. And that's linked with the next one, that if we have timely collected data, we could be better informed to create policies that actually take into account both the whole population, but also those ones they are in a minority or they have a vulnerable position. Now with this one though, how the system is, I guess, drafted or delivered, it's that getting data, although it's collected routinely and it's there, for us as researchers, it's a bit difficult. So you have to go through a process, through ethics. You need to have several approvals. So it's making having real data, it's making a delay at the best of times. So I guess the challenge is how can we use that data to inform policies, to inform structures, models of care, and so on, that they are timely available to us and to others. And I think that's the challenge. So this is the conclusion. So when responding to pandemics, decision makers using quality real-time data have to draft things that actually can work in real life. And I know this is a challenge, and this is a challenge about all the health systems, how to cater to the general population and those who are more in a vulnerable position. So I think that that's the real challenge we've got going forward. on how to use our data, how to meet the needs of those in most need. And that could be both. It could be a social needs and health needs together. And don't forget our priority populations, which they need it the most. And I have this little photo here. So we got the reality, have the equality, the equity, and the liberation. You know, I'm hoping that we move in here, but I know that we have setbacks, so we go back there, and then we go forward. And well, that's very far. Maybe one day we get to liberation, but at the moment we need to circle this, and we go back and forward, back and forward. And I guess it's a learning process, but hopefully we can get to that point. That would be nice. And well, we will have questions, I guess, at the very end. But in the meantime, get in touch. I got 2 different Twitter handles that I might be changing to something else because Twitter is a bit polemic. And then that's my email. So if you have any questions, email me.
Thank you, Eliana. Now, don't go anywhere. I'm not sure how does this work, Marcello, please? Interact with the people on Zoom to ask if they have any questions.
You can talk.
I can talk. Do you hear me from Zoom? Yeah, the problem is that I can't see the chat, so if they write on the chat. You know what you're doing, or you just stop?
Let's hope it down.
You're making this up. All right. Is there anyone in a no? Which one? Preview? No. Is there any questions from the audience on Zoom? Before there was something there. Maybe we're not connected anymore. Let me just connect to this. All right, while I figure this out.
Wait. I'm gonna go outside and manage from outside. You hear me from Zoom? I can't make contact with the people on Zoom.
Okay.
Do you hear me from Zoom? Can anybody respond to me? Shout, Ryan. Okay.
Francesco, we can hear you.
Oh, beautiful. Sorry, guys. We're having a bit of problem here. Do you have any questions there? Okay. Is there anyone with the question? You can hear me? The audio is bad. Okay, I don't know what's the problem.
So I think if we go from here, it should be fine.
Okay, if you have any questions, guys from Zoom, type it here on the chat. Thank you so much.
I have 2 questions.
It's unmuted?
Yeah.
Okay.
Yeah, so there was I don't know why, but it seems not to connect with this very well.
That's all right. That's good.
So I'm collecting the questions
Outside.
on the chat outside.
Yes.
But while I go, did you ask your question?
No.
All right, great.
So first of all, thanks for the presentation, very interesting. I have two questions. The first one is methodological.
Yeah.
So I saw that you run a logistic regression.
Yes.
I didn't get the dependent variable that you use.
Yes.
So this is the first one, and then maybe why you use that model. The second one is more about like the going forward. So given that we saw that there is a clear disadvantage for vulnerable people,
Yeah.
even during restrictions, clearly because of their need to probably go to work because they are workers in essential, let's say, area,
Yeah.
etc.
I
So
get
they
that.
need to go out from the home. They cannot work from home. So what would be, in your opinion, like the policy learnings that we can get from this experience going forward? So in the next pandemic or public health crisis, would you, for example, would you, for example, provide progressive subsidies to people in lower economic classes, or what would be like a nice or effective solution to avoid these higher infection rates that we observe?
So the first question is why we use that methodology. What we run to separate COX models. So we couldn't put it together, so we decided to separate, and dependent of variables was actually COVID infection. The rest of the stuff came after, and so well, we got that data, let's put it in. So that's that. Now the revisions that we have, because we submitted the paper, we've been revised it, they're all concerned about the actual methodology and why we would put it together. But because this was retrospective and then our statistical advice said let's do it that way. But yeah, I can see that there can be some, hard to tease from the get-go, but it's the data that we had and the way that we collected. Now for the second one, so you think health workers priority, which are performing priority work, we're not part of this in the way that we phrase it. These are people that perhaps don't even have a job. So health workers, for example, they have much more risk of impacting, but they're not the same cohort that we are talking in this study. We are talking of people that perhaps are receiving disability pensions, they're living in a house that they live with another 4 or 5 people. There's also the homelessness part. So frontline workers in our vulnerable populations are not the same. So we can't kind of conclude anything from it. So it's a different animal. And we also had a few comments on that and clarify exactly what is this data related to. So there's then nothing to do with essential workers. Even migrants with less stable jobs, they're not our frontline workers. Most of them do not have a job. So yeah, that's the difference between what we thought it could be and what actually is.
Right, good. I mean, maybe a follow-up from Marcello's question. So I guess what he wants to go with, and that was also quite what I was curious about, is the so what part of the question, right? So the public policy element, right? So if you think in terms of, okay, the gradient, so there is a gradient, socioeconomic gradient, and it's the same everywhere, I suppose, in the world. What you saw in a study that we did in actually Latin America is that you saw, in fact, I would say the complete ineffectiveness of a lot of the restriction policies, because people need to move, and by movement, some people, the lower the socioeconomic, in fact, what we found, the more they need to move. and to be in contact with others because of the nature of their labor, whether it's formal or informal. The ability to make a living requires contact with people and a lot of mobility. Now, is that the same group in Sydney? And if so, or in Australia in general, and if so, is there a public policy really in a country that has, sort of the strength or thinks to have a kind of a big enough social support?
That's the thing.
Yeah,
Is the social support.
It's the social support. So what you find is that what's interesting, I think, is that you still find this gradient here.
Yes, there is.
And my question is that given that the level of social support is so high, is there any other public policy that is going to be effective? Because if you provide additional subsidy, would that deter movement, or is instead the conditions of living here of these people, like you said, crowded houses or unaffordable housing? So is it subsidies the solution, or it's more infrastructure? I mean, if that's the case, what's the public policy in the future? Do we have to rethink the whole approach to social housing in this country, or other things?
I think it's all about a bigger issue, that it's not just putting money in people's pockets, not also putting money in services just the way it is. So there you got the money. So I was having an interesting conversation last week about the actual, not just the health policy, but about the actual health system. Whereas one of the people I work with was saying, this is not about money. It has nothing to do with money, in fact. It's the way that we are designing the systems and whether the policies are backing up those systems or vice versa. So what's first, the policy or the functioning? And he was saying, look, I don't know how to fix this. I just don't, and and inside as someone working there in a high kind of clinical directory level, where this is not simple. And that's why we're having so many difficulties in addressing all the needs of the population. It's not one way, not one stop for all, basically. And in terms of the social security, yes, we have in Australia a very gifted social security program that it's nowhere near in South America. Yeah, there's some social security, yes, there is, but not to the level that there is here. And they are targeting more pressing needs. So I found that in places where the social security and the policy are a bit weaker, they tend to address what it's more as an emergency rather than plan ahead. Even in Australia, I do think that we don't plan ahead either that well. And we still have so much to do and so much to understand. And that's what my last, one of my last slides were all about. Like, where are we? What are we fluctuating? And I think we're fluctuating. Like in COVID, we come back to the reality, and then we wanted to go for equality and equity. I don't think it's one thing, and now we're here and we're all good and that's done. I don't think so. I think it moves. Like a diagnosis is moved. The person is not just the person is going to have a diagnosis and then tomorrow might fluctuate to something else and then come back. So it's not just square thing where we put money and we put 2 or 3 heads together and we solve this. So that's why we're so confident. And that's why I guess we are employed and we're here, because it's not an easy fix. Do you have the answers?
No, I
don't have the answers either.
Today I'm only asking questions or facilitating. Any questions here? No? No?
Okay.
Let me just go. Yeah,
I have one. It's just about, so you look at all those different demographic factors and how that impacted infection rate, right? Did you look at interaction factors as in compounding things? So
We adjust for things. We adjust for things, but compounders no. What happened is we took whatever the ABS database had and used those. So we were not, obviously, if we run the study, yeah, we'll try to obviously have it done in a better way, but we use routinely collected data. So what do we have? We have this. Okay, let's put it in a model. But yeah, obviously, One of the other criticisms of this study that we just took data that was already there and we did anything else. You probably wanted to tease out why those vulnerable populations are in that condition. You would mostly like to have at least some qualitative study around those groups that you find that have more challenges and barriers. And if they have any facilitators from other ones, you also want to know what facilitators, how can we make it better? So, for example, for migrant culturally diverse populations, anecdotally, we knew that there was a disadvantage, that there were barriers. So, for example, the Australian government in 2022, but at the early, they created a health advisory group, but it was linked to the government around how to communicate with culturally migrants and refugees, how to, in the context of COVID pandemic. And it came as a response of what they were seeing on the ground, anecdotally. And they still meet because there's still a need, but this is just existing inequalities that got enhanced by COVID in the first place. So we had that, we had those. It's not that they were not there, but just COVID showed everything in it. It showed the health impacts, but also how the social factors were also important for that big event that happened to us, 2 years ago.
Actually, you challenged me. I thought about to be provocative a little bit.
Yeah,
if you think about the policy that you're analyzing, which is the restrictions on off, and then you think about what you're presenting there, that in itself is unequal, right? Introducing a restriction, I'm being provocative, of that kind, by definition, creates an inequality, right? So if you flip the story a little bit, because you're restricting, it's a one-size-fits-all measure that by default, you're restricting mobility. If I need more mobility to generate income or whatever, by definition, it's one-size-fits-all. You're not going to make a mistake. If you apply one rule that is equal, you're going to create to all, you're going to create inequality. It's like one of the most frequent paradoxes that you find in public policy. The one thing we know is that if you use one tool for everybody, and of course public policy does that all the time, it's certainly, in any area, it's certainly going to create inequality. 100%. You can apply taxation is like that. Everything. You can think about I can quote you on a lot of them. Non-smoking policy. It affects more poor than rich individuals. And so on. You can make all the public policy. So now, one more equitable approach, like the Swedish did from the very beginning, was okay. We're not going to do the restrictions. Now, I'm exaggerating because, as we know, that approach was more, different shades between white and black, right? So, but they were kind of adapted to the situation. That's the perception they gave. So, in fact, their public policy was more flexible. Nevertheless, huge inequality, cultural related. That was the degree of infraction. But then their justification from a public policy perspective was, well, we didn't force you inside your confined community or house. Then it's your responsibility.
Yeah.
So what's interesting about that reality, equality, equity sort of liberation is probably the trade-off, or if you want, a balance that you need to strike between collective action and personal responsibility. That is what gives that depth. But if you really think about it, it would have been more equitable not to have any restriction, and then have what you have, in fact, as the picture afterwards, so that everybody, rich and poor, educated or not, get all equally infected, and then let the public system deal with the problem.
Yeah.
So if you want equality, there is a huge risk, and that's where my question is. If the objective in this, and I'm being provocative, of course, is equality, then you have another issue, which is a massive infection rate, right? So what do you do? Because then you have a real trade-off. Do I apply one, size-fit-all policy that seems to create
A big gap.
a gap between different SCS, or you instead go for maintaining equality there, but then have to, sort of, deal with more infections in the community, which is what we're doing now. And probably, it's a public system, so it's a lottery, right? Rich and poor don't matter or shouldn't matter. And so anyway, I agree with that.
I think I agree with you with imposing something to everybody, knowing that in the first place they're all in different positions. And yeah, completely agree with you. But you can come up with other things. I'm also being provocative here. You could say, well, now that we know that that type of policy worked for the mainstream, let's keep that to them because we already know that they're good for them. It works. But for these minority groups, vulnerable groups, those measures make them worse. So let's create new ones for them. Now, whether that's fair or not, I don't know. However, they are in a different place anyway from the very beginning. So maybe might as well do a mainstream one that are going to respond really well, and they got money, they're happy, whatever. And some other ones for these groups that those measures that we impose on them, they're not really helpful. Do we need to create something different to all of it? Do we need to have an alternative way of thinking? I don't know. I've been provocative.
Yeah, sure. No, it's good. So, baby, are there any questions?
The only comment was, well, that's what we currently do with Indigenous groups, don't we? We give them different, well, not rules, but health programs,
Approaches.
Different subsidies, offerings, to try and find out what works for them.
Good. So basically, sorry, any other things here? No, all good. I'll pop outside to see whether online. Sorry again, and thanks for bearing with us. But to conclude, really, to continuing this journey towards more equity in general and health equity in particular, probably we have to think about less symmetric ways of dealing with some of the problems. I want to ask you to join me in thanking Gabriela. Thank you for those bearing with us online. I understand it was visually and from an audio perspective all fine. The interaction we're going to try and fix in the lunch break. Stay with us. As I discussed before, we had a little swap, but Oona is now here with us, and she'll follow up shortly. Probably give us about 10 minutes to get organized a little bit, and for you there is lunch. So see you later. Thanks. Scanning. We can use our staff. Thank you, Gabriela.
Brandon, sorry, we missed your questions, but as soon as we get back in, we'll answer it. Sorry, we have having problem with Zoom today. Thanks for this.
Okay, welcome everyone again for round 2. Now, as I said before, to change orders a little bit, I would like to welcome Oona Reardon. So the talk of Oona is on the economic analysis of targeted intraoperative radiotherapy, TARGIT-IORT, TARGIT.
IORT.
Okay, IORT, for early stage breast cancer in Australia. Oona is the founder and director of Pulse Economics, which is an health consultancy here in Australia. He's a health economist with several years of experience in economic evaluation, and both in consultancy, private industry, and academia. She was at CHERE at UTS. In the past, she's worked on with a range of clients on market access issues, dealing with PBAC and MSAC reimbursement submissions. I'm very thankful for Oona to join us today and to present. For those who are online, trusting you hear us and see us still, we'll use the same system as we used before, and encourage you to interact with our chat box. I'll collect the questions again, and at the end of the presentation, if you can, of course, write them while they come up in your minds. Then at the end, I'm able really to collect them and post them to Oona. Oona, thank you.
Francesco. So the research I'm presenting today was part of my Masters of Public Health, which I completed at CHERE. I'm hoping to publish this research next year. In terms of disclosures, I was subsequently commissioned by the manufacturer of the intraoperative radiation device to write an economic evaluation report following my MPH. The breast cancer in Australia is the most common type of most common type of cancer for women. So approximately 20,000 women are diagnosed each year, and the mean age of diagnosis is 62 years. 5-year survival is approximately 90%, which is quite good. So for early stage breast cancer, that's defined as when the tumour has not spread beyond the affected breast or the lymph node under the armpit. The most common type is invasive carcinoma. So the current treatment path for early breast cancer in Australia is breast conserving surgery or a lumpectomy, followed by hypofractionated whole breast cell beam radiation therapy. hypofractionated means is that there's been a reduction in the number of fractions that women need from previous years. They used to need 25 to 26 fractions. Now they only require 15 to 16. This type of radiation therapy is given in the outpatient setting. Also, patients under the age of 60 will require a tumour bed boost dose, which will be another 45 fractions. Adjuvant therapy can include chemotherapy, hormone therapy, or targeted therapy, and a mastectomy in these patients is uncommon. So a new type of treatment intervention is intraoperative radiation therapy. So this is given as a single dose to patients of 20 gray immediately following the excision of the lesion of the breast, so before the cavity is sewn up in the operating theatre. Administered by a handheld device, and there's two types of designs. The applicator, there's a balloon applicator, the acid system, and also a plastic spherical applicator. Treatment time varies on the size of the applicator, but it usually ranges between 8 to 15 or even 20 minutes. So clinicians have informed me that there's no increase to the recovery time for women who undergo the IORT compared to those that don't receive it. IORT can be given to women in the surgical theatre in the hospital, but also there is one issue with Queensland. It's the only state that mandates that lead shielding must be in the walls for when the IORT is given. Here's the clinical management algorithm. There's two pathways. So patients on the left pathway will receive IORT following the lumpectomy. And then following this and their recovery, they will have their pathology taken. If they have abnormal pathology results, they will require also a whole course of whole breast radiation. Patients going down the right pathway, they will have their breast conserving surgery and then wait 4 to 6 weeks while their tissue recovers, and then they will have their fractions of radiation. As you can see also, so all patients, no matter which pathway, if you're under 60, will also require the treatment. What does the clinical trial data show us in terms of the comparative effectiveness and safety of these two treatments? So I conducted a literature review, and there was only one clinical trial, which was a phase 3 non-inferiority trial called TARGIT-A, which compared these two treatments in women aged more than 45 years with early breast cancer. So the point to note here that patients on the left that underwent the risk-adapted intraoperative, there were some differences between how the countries treated these patients. And that's because, so this was a multi-center international trial, so 10 countries participated, but there was slight differences that some countries might give 15 or 16 fractions, like in Australia, or other countries might give 26 fractions. Okay, so here we have the consort diagram, and there was minimal crossover between the two arms. There was only about 5% patients who crossed over from IORT to EBRT and less than 3% crossed over from EBRT. Baseline characteristics of these patients were similar to what I've mentioned previously, what we have in Australia. The median age was 63 years. Most women were aged 51 to 70 and had a small tumour size, that is less than 2 centimetres. The most important thing for this analysis is that there was no significant difference between the demographic and disease characteristics between the treatment arms. So here we have a comparison of the treatment regimen. Patients received IORT, followed by 21% of them requiring the additional whole breast radiation therapy following abnormal pathology results. And you can see on the right the patients there receiving the whole breast RT. Patients in both arms, the majority of them received the hormone therapy and approximately 20% received chemotherapy. I'm going into a lot of detail here about what the difference is between the trial arms, but that's important because in the economic model, all this needs to be taken into account. So here we have the results from the trial. The results of the primary efficacy outcome was the difference in local occurrence between treatment arms at 5 years. So the trial investigators, they had a predefined non-inferiority margin of 2.5%. That could be the risk difference between the two arms. You can see here it was actually met because there was only a risk difference of 1.16%. There's also no significant difference in secondary outcomes of breast cancer mortality and overall mortality. However, there was a significant difference in non-breast cancer mortality. So with IORT, it was significantly lower, only 3.9% compared to patients receiving the external beam radiation therapy of 6.4%. In terms of the safety results, the only difference was the skin toxicity, that's grade 3 or 4, between the two treatments. So for intraoperative radiation therapy, it was significantly lower, only 0.2% compared to EBRT, 0.8%. Exploratory outcome is the cosmetic results. So there was a UK group who did a post-hoc analysis of TARGIT-A patients in computer software to detect difference in symmetry, colour and scar to produce a composite score. And what the investigators found that for women in the TARGIT-A trial, there was a statistically significant increase in patients having an excellent or good cosmetic score following IORT compared to. And a point to note also is with external beam radiation therapy, some of this skin, some of the changes in the skin can be permanent. So in terms of the clinical conclusion, we could say there's slight ambiguity, and that's because although the results show us that there is non-inferior clinical outcomes between the two treatments in terms of local recurrence, also overall mortality. There's a difference in clinical outcomes for non-breast cancer deaths and skin toxicity. So with this in mind, I accepted that there could be two interpretations for this evidence, and I developed two economic models. So I constructed two models comparing the two therapies. First model assumed non-inferiority between the treatments, so that was a cost minimization analysis. And the second model assumed different outcomes between the therapies, so that was a cost utility. Clinical inputs and assumptions were sourced from the TARGIT-A trial, clinical opinion, and published literature. Another assumption in the models was that I had only had contact with the manufacturer of the ASCENT device. But the ASCENT device wasn't used in the trial. So when I looked at some technical papers, it looked like these devices were technically equivalent. So I made that assumption. So to calculate the number of procedures per IORT device in a hospital, I assumed that each hospital size would have a catchment of 1 million. And then I times the incident number of breast cancer cases times 16% and calculated that each hospital with that device could perform 104 procedures annually. Resource use and costs were quite complicated because there was so many different award rates for all the different staff that was involved, and then all the different timings for the procedures. The capital costs for the linear accelerator as well as for the IORT were significant. You can see there the IORT asset system is approximately $650,000. And then there's also inpatient and outpatient patient costs as well as costs for AE management. So the results of the CMA show that IORT costs less than EBRT by about $2,500. I also conducted some sensitivity analysis. One of them was a quasi-societal perspective, which incorporated if 10% of the patients had to quit their work or considered their time as $225 a day, which is the minimum wage, then how would that change the results? And you can see there the difference then increases to $2,700. And then the last sensitivity analysis there is to determine what it would be the minimum number of patients that IORT would have to treat per hospital to be cost effective. That's because the outlay cost is $650,000 to set up the machine. Of course, you're going to have a minimum number of patients going through, and I determined that number to be 49 patients per year. So for the second model, so this is where we assume superior outcomes or superior or different outcomes for IORT versus EBRT. And for here, I modelled life years and quality adjusted life years using triage software. So quality adjusted life years is a life year in perfect health. And I wanted to calculate the ISA, which is the incremental cost effectiveness ratio, and that represents the economic value of therapy B to therapy A. So the ISA provides that health, well not only me, but in this analysis, but provides the decision makers a tool where they can compare cost per clinical benefit between therapies. So for instance, monotherapy analysis, and that's how they work it in the and so I adopted identical treatment assumptions to the CMA except for the structure of the model. Here there's 6 distinct health states. So patients enter the recurrence-free health state and then either remain in the recurrence-free health state or they might move to the local recurrence or death to other causes. So you can see there, so each arrow is a possible health state that the patient can move to. The model only permitted 1 local recurrence due to the data available from the clinical trial, and also death from breast cancer could only occur following the health state of any other occurrence. So the components of the model are presented here. We have a time horizon of 15 years with a 1-year cycle length. The methods used to generate the results, we had a hypothetical cohort of 1,000 patients, starting at 60 years. And some of the transition probabilities were sourced from published data. So transition probabilities is the probability of a patient transitioning from one health stage to another. The utilities there, that were derived from published literature. So a utility is a value between 0 and 1, which denotes the patient's preference of being in that health stage. Assuming you all know something about utilities. All right, so the results of the Markov model are here. So the incremental cost remains in favour of IORT. And the incremental outcomes were 0.3 life years or 0.3 polys. So we can say that IORT dominated EBRT. Sensitivity analysis, I used ABS background mortality data rather than mortality data from the trial. And this resulted in $56,000 per coin lost. Tornado diagrams presented here for the CUA sensitivity analysis. The key drivers of the ISA were the time horizon and the number of EBRT fractions. So the costs were similar between the base case model costs, between $2,000 and $2,500. However, I'd like to point out there was quite a few transitivity issues. So these included, as I mentioned, the heterogeneity in the treatment regimen between the treatment groups with TARGIT-A. There's also variation in resource use between public and private hospitals. So I just looked at private hospitals. And then I also didn't consider Queensland hospitals, which would require a surgical room with lead shielding. There's limited quality of life data. And then also there was a different device used in TARGIT-A compared to clinical. I was saying that actually intrabeam is used in Western Australia by one clinician, but I wasn't in contact with the intrabeam manufacturers, so I couldn't get any costs. And there is also some discussion in the literature that the non-breast cancer death rate in TARGIT-A, although it was statistically lower with IORT, because there was so few deaths, we can't really take that as a reliable. The other considerations for the difference in these therapies is the patient advantages. There's improved convenience for patients that live in rural and regional areas or that don't want to take time off work. For instance, for parents that have young children. And also an Australian preference study found that 23% of early breast cancer patients would accept an increased risk in local recurrence in the trade-off for convenience. And patients also are relying on their minimum wage for their work. They're not really going to want to undergo all that radiation. And lastly, there's the lower risk of the permanent cosmetic skin changes that I think for women, well, I think for any patient, is how you're going to look afterwards. And I've added this last point in about lower risk of spreading infectious disease. The other considerations include, how the healthcare system is going to have to adapt with IORT. There will need to be more training, considerable time spent on the workflow management because all these different specialists coming into the surgical room and the recovery time. And then also that the smaller hospitals aren't going to have the financial backing or the capacity to undergo having this new type of therapy. So possibly there's going to be an increased demand on major hospitals that adopt. But in conclusion, the IORT using the asset system is cost-effective compared to current practice in the Australian setting for these patients, providing there's at least 49 patients treated per year. And then my last point is, I've noticed even though this procedure was listed in 2017 on the NBS, and then the second brand was added in 2021, there's still very limited uptake of this procedure in Australia. Which makes me wonder, what are the barriers to change? I know that some clinicians are very positive about this new type of therapy. Why aren't more major hospitals adopting it? I'd like to conclude.
Thank you. Any questions?
You have a personal opinion on why, in fact, the local hospitals aren't taking the IORT, buying the machines or?
Yeah. I know, so the clinician that I've spoken to, Monash Cancer Care Centre in Victoria, so yeah, they're very keen on it. I feel like it's maybe the clinicians want to experience and see the results themselves rather than relying on other people's say. But perhaps what could happen is the clinician could have a trial experience of going to different to see how it's performed, and then the results over time. Perhaps more publications say what does change clinicians' behaviour. Guidelines.
It's a new procedure, right?
New procedure.
Yeah.
It's been listed on the MBS for 5 years. So I can see in the Medicare statistics that, one clinician in WA that does quite a few of them, and then Victoria does a lot.
I'm going the same way. So what's your, certainly the first question would be, is there any study that looks at physician preferences and trades them off, or what are your thoughts? There must be some barrier of some kind. Maybe I missed something, but.
Well, I know when I used to work in Liverpool Hospital, so what used to happen is, so the clinicians would go to some international conference, and then they would come back and they'd be all inspired by a new type of device, and then they would say, we have to get this into the hospital, and then they would all be, and then they would talk to the politicians, and then they get the funding, and then it would eventually happen. But that's that. I know of that pathway. I think with clinicians, I think some of us are very set in their ways.
What about just to keep the flow in my mind, what about the framework that we have to absorb innovation? Certainly there is some economic evaluation, but it's not the nice either. We don't have a threshold. What do you think about something a bit more prescriptive, right? So the reason you tech works great, use it. And that's pretty much what you would have in a more, let's say, top-down UK-based model, or even other models like in the Netherlands. They would go to the multiple stakeholders, ask them questions. These are the criteria. One is cost effectiveness, another one is the burden of disease. Clearly, this is breast cancer would be top of the debate. what's your opinion about our system? Given that it seems to be not only for this, but the diffusion of technology seems to be very political. Is that what we want?
Yeah, no, I think we definitely don't want that. And another example of when I worked at Liverpool Hospital was the politicians wanted a new cancer therapy centre implemented at Campbelltown Hospital. So then the medical, because I used to work as a medical officer, so we spent a year calibrating it all, getting it all ready, and then there was a launch date. The politician came in and cut the ribbon, and then the equipment was just sitting there. There was 2 linear accelerators, and one was being used for less than half a day because there wasn't enough patients in the area. And then that drove me a bit crazy because I just thought, well, all those resources that we put in, and we've suggested other projects which would actually benefit the patients, haven't been implemented. So yeah, it's very political. So I don't really have an answer to that, but. The local politicians want their votes from the people, and so.
Interesting.
How sad.
Interesting. Any questions from, I don't know, around here? No. Yeah. Hold your thoughts, because I mean, this is just to involve the people online. Any questions online? Sorry, guy, but
okay,
no, it's okay. 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 Has there been? So thank you, Brandon, for your question. Has there been differences in uptake between public and private hospitals? Is this a radiologist or surgeon decision to recommend the procedure?
Yeah, so the first question, as far as I know, it isn't being implemented in any private hospital as yet. They would have to pay for it because that's the knowledge. And sorry, what's the second question?
Is this a radiologist or surgeon decision to recommend the procedure?
Yeah, that's a good question. Yeah, I'm not sure about all hospitals. I know, so at the Monash Centre, there's a surgeon, the main clinicians I was speaking to was one surgeon, one oncologist. And they work very closely together. The pathway of how a woman is diagnosed with breast cancer, and who do they speak with first about their diagnosis and then their treatment options? I would think that it would be oncologist, but oncologist would need to make the call.
Yes.
Then it would need to point them to the surgeon.
Yes,
So,
that would be my best guess.
Yeah.
But the world is full of surprises. But Anne-Marie actually made that comment. So she's also the. I do think it's the oncologist ultimately.
Yeah.
Well, definitely initiating, and of course there is always. Well, the will, at least, or the attempt to have multiple teams, especially, or multiple people, especially if there is radiotherapy involved and things like that. So definitely, a team approach would be ideal, but the oncologist, I think, is the key. My understanding is that it's multidisciplinary. Thank you, Marie, agreeing with my comments. Certainly, Marie, very expert in this. So thanks. Any other questions now, Chiara?
No, I was wondering whether you know about experience of other countries if this worked.
Yeah, so I had a look just briefly. I saw in Taiwan, there's quite a big uptake in IORT. Not sure what the funding model is like there. Yeah, I do feel like, so Zoft manufacturer of the asset device, I think they're based in Europe, possibly. Yeah, they're people, I don't think they have that many people on the ground, so I don't know why. Yeah, maybe just in terms of ease of implementation, they're focused on certain countries. But I know, for instance, they don't have any product managers from their own company in Australia at the moment. They were working through Regional Healthcare Group, which is more like a distributor. No one on the ground going around to the doctors trying to change.
Okay, very good. Other questions?
Just like quick questions about the follow-up from the study. So I saw that you mentioned like a preference study.
Oh yeah.
So I was thinking whether you are thinking to run a study preference experiment to understand individual preferences for the treatment. Or
He's offering himself.
No.
I know with preference studies here, there's a lot of work involved. I do know a preference group actually. A pre. And now, so they used to
like the beautiful island in front of them.
No, CAPP. So they used to be academics and researchers, but then they realised that for these these preference studies, there's so much demand for them. We can use them in so many areas. That they've just created their own private company, and then they're offering offering their services for a fee for people that are interested in the results. But yeah, if you're asking me if I'm going to do it, probably not, because I run a company and I'm pretty busy at the moment. But yeah, if I'm ever twiddling my thumbs, I mean, it's such a study into preferences of how we do change clinicians' behaviour in hospitals. That would be really useful, obviously.
Yeah, or maybe higher level, in fact, not necessarily only clinicians, right?
Yeah.
Because it's about, if you not, there is pretty big literature on preference elicitation on that, not only in healthcare. Definitely something Marcello likes to do, we do as well. We're not a consultant, so we're much more cost effective. But I thank you for this. Any other questions online or here? Gabriela here?
I think that you, the people, the hospitals, the clinicians, for a long run, I found that in previous studies that have trained clinicians to the uptake of evidence-based practices within the public system, we use clinical champions or change agents. So, and that's, I guess, it's a concept borrowed from implementation science, where you use what you commonly think that could help, and that clinical champion not only has respect in the formal way, but also informal. But I'm not sure whether you're there yet, because usually these uptakes of evidence and practice, like it took about 20 years to get to the point that there's enough evidence to indicate that that's a way forward. Then there's a system, and the system has got people. And I found when we're talking about people, clinicians and people in an organization, somehow it gets really difficult. Although you know all the answers, you have the tools, you got the evidence and the information. What we're not very good at is actually factoring for individual, I guess, beliefs and habits and the climate, the organizational climate within the hospital. And I think that's where, I guess, a change agent or a clinical champion can come in. And even then, when you have all the structures and you have the clinical champion, there's a little bit of work that needs to be done with the team of people in the hospital, because they have all their own self-culture. And so it's not as straightforward either. So I think you need to be there for a while and then stay there. And usually a change agent, you might think, oh, I'm going to go and get someone from the outside and do something, some sort of training, in-house training. But then the person goes back and there's no one there helping people or providing supervision, because this is a little bit of clinical supervision as well, and providing, no, yeah, this works, and so on. And so it could be like a change agent in-house, permanent type of thing. But I don't know. That's just a
Okay.
thought.
Good.
Expensive thought.
Yeah, no, I like that.
Very
Because I know
expensive thought.
when we submit an economic evaluation report to the MSAC, there is, what needs to happen afterwards, after the services listed on Medicare, whether it's training, but yes, actually could be, how is the change going to be implemented?
Yeah, and I know this by experience because I work in that thing, and I know the clinical champion, and it's employed permanent. I like
Okay.
that.
Yeah, interesting. So also very interesting and thought-provoking from Zoom. I was about to say from the internet. That would have made me extremely unfashionable, but there you go. Thank you, Oona, again, and thank you, Gabriela. Please join me thanking them again. Before we say goodbye, our good Brandon clapped his hand and asks, would pushing the patient benefits beyond the economic impact assist to drive change?
Yeah, I think it will, because I know lately with Medicines Australia and also the Department of Health, they're placing more importance on the patient preferences and how the patient is, their viewpoint on not only medicines but also medical services. So I think, and now there's much more patient groups, patient voice representatives. So I think that's a really good idea.
Wonderful. Thank you also for you guys attending online, and have a good break. This is our last seminar for the year, or the last seminars for the year. We'll see you next year.
Yeah, it was great.